A question a lot of people have is, how do I know if my vulvodynia and pudendal neuralgia and even my interstitial cystitis is caused by pelvic floor dysfunction, and how do I rule out that it's not caused by that? And that's a really valid question, because not everyone has access to really great and knowledgeable pelvic floor PTs. And even when you do, it can take time for them to work on your muscles to be able to say, okay, you don't have pelvic floor dysfunction, therefore if you still have pain, it's not caused by that. And sometimes people go through pelvic floor PT and they get discharged and they still have some degree of muscle dysfunction. And that brings me to the second point of why it's so difficult to find out sometimes, is because there's this bidirectional possibility of pain generation with pelvic floor dysfunction. And that's illustrated here in the Center for Vulvovaginal Disorders, Andrew Goldstein's and company's treatment algorithm for vulvodynia. You can see that arrow over there is going both directions. So pelvic floor muscle dysfunction can cause pudendal neuralgia. Pudendal neuralgia and persistent genital arousal disorder can cause pelvic floor muscle dysfunction. Over here at the top, it's saying pain confined to the posterior vestibule, so 6 o'clock, the back of your vaginal entrance. Or it also says from 4 to 8 o'clock if the vagina opening is a clock, and 12 o'clock is the top, your clitoris or urethra. So 4 to 8 would be that bottom portion. Oh, it says it right there, pain at 4 to 8 o'clock. And this graphic even specifies pain at 6 o'clock was coming from hypertonus, so tonus, toned, tight, hyper a lot. So a lot of tightness of the puborectalis. So I believe the puborectalis and the pubococcygeus are part of the levator ani muscles. And I think there's 4 of them, and they are part of the pelvic bowl or the pelvic floor. And I would add to this, and I can put my sources if you ask me for them, but the obturator internus is also implicated in pudendal neuralgia. So when the pelvic floor is the cause of the PN, that muscle being hypertonic, the PN often runs through it or along it, and that can cause those symptoms. And the obturator internus, I believe, is not part of the levator ani. Correct me if I'm wrong. So anyway, rectal fissures, hemorrhoids, these external, even constipation is involved with pelvic floor dysfunction there. Anxiety is a psychological mechanism which can trigger pelvic floor dysfunction. But something like it says here, excessive core strengthening exercises, like someone who's been like a muscle trainer, what's the better word for that? I'm sorry. A very athletic person, a weight bodybuilder. And I would go so far to say as potentially people with hypermobility and hypermobile Ehlers-Danlos might have pelvic floor dysfunction as a non-anxiety, non-psychological cause, because you have this instability in your pelvis and hips that might cause secondary tightening of the pelvic floor muscles. But going back up here to pain confined to the back of the vestibule, this is the other half of this graphic, and this says tenderness throughout the entire vestibule. But if you see that little line right there, that one says if you have the entire vestibule, but you have the worst pain at the back, that indicates pelvic floor muscle involvement. Because otherwise, having equally pain, like provoked vestibulodynia, vestibule, indicates some other potential causes: neuroproliferation, inflammatory, hormonally mediated. And going back to this bidirectional thing, PN causes PFD and pelvic floor dysfunction causes pudendal neuralgia. I would suggest, as a patient, it's not my job, or I don't know if I'm allowed to say what I think. I'm going to say it anyway. I feel like I've seen it discussed that if you're living with chronic pain from hormonal deficiency, you have compromised skin tissue there from atrophy or chronic infections, like just that pain, the actual real pain that you're living with, can cause secondary tightening of your pelvic floor muscles. So it can be in response to, I think, all the other causes of vulvodynia. And on top of that, as an interstitial cystitis patient, who a lot of my symptoms were caused by hormonal atrophy, I can tell you that when you're peeing 40 fucking times a day, your pelvic floor gets real messed up. So basically at this point, you don't know if pelvic floor dysfunction is causing your symptoms really, or if it's caused by them. And I'm only going to speak for myself, but for me, the way to rule it out, because I do not have any pelvic floor muscle dysfunction involvement causing my problems. But that didn't stop many, many doctors and physical therapists and random people hearing, oh, pelvic pain? you must need pelvic floor muscle physical therapy. Like 4 years, even after I said I've been doing it for 5 years, and I do it every day on myself for another 3 years. And now I've seen 3 more people and I spent more months doing it. So that's the first way you can rule it out, is to go to physical therapy. I think everyone should get an assessment. I think it's important to note that at no point in my many wonderful physical therapists did anyone ever really say like, oh my gosh, your pelvic floor muscles are so tight. It was always more like, well, they're kind of tight. Maybe we can help you by getting a little bit more looseness here. They were definitely sore, but again, like that can be caused by the other causes, like peeing way too many times abnormally throughout the day could cause, I think, soreness, or having loose ligaments and having to tighten to do athletic activities because you need to stabilize yourself. But in terms of having like a vaginismus level of clenched pelvic floor muscles, like I never had that. But I was so determined to rule this cause out. I mean, it is important and it can cause so many of my problems that I was determined to do this. So I think, the number one way for me to completely rule out pelvic floor muscle dysfunction was injecting my pelvic floor full of Botox. So that will forcibly relax your pelvic floor muscles. So I did various kinds of pelvic floor muscle Botox on 4 different occasions in the course of like 9 months. I think the most I had injected at one point was 250 units in one session. The first time it was only 100 units. And so of course I looked into it and it goes up to 400 units. So I had to make sure that I didn't just not do enough. I had to make sure that the obturator internus, which was the one that can be most connected to pudendal neuralgia, got enough. So I had to get a separate one just of 100 units or 150 units just into my right OI. And nothing changed. And nothing changes for me really after pelvic floor myofascial manual release that either a wonderful trained professional is doing or that I'm doing on myself with my TheraWand or my hand. On top of that, often people are given muscle relaxing suppositories or just oral muscle relaxers. So again, if that was causing your problems, like any part of the root cause, you would think that a combination of pelvic floor physical therapy, actually doing that work, having your therapist say, oh, you're improving, and then taking muscle relaxing medications, if that was part of your pain, that would create an improvement. So if you're taking, okay, I gotta speak for myself. I'm taking muscle relaxers and I'm getting 0 change in my vestibule sensations, in my urinary tract symptoms. In fact, sometimes muscle relaxers make my bladder worse because they kind of paralyze the detrusor muscle. Detrusor muscle has to contract for you to void. And so anything that kind of inhibits my detrusor muscle contractility and my urethral sphincter, it's naturally tight. And so it needs to actually open for you to pee, and the relaxation makes that harder. So muscle relaxants actually were kind of flaring me, not making me feel better. So I ruled out pelvic floor muscle dysfunction by extensively consulting with pelvic floor physical therapists. I saw multiple different therapists. I also worked on myself. I also read multiple books about pelvic floor physical therapy, including A Headache in the Pelvis, which is like the most academic version, to just pelvic liberation, which is about like pelvic yoga. I tried 4 or 5 different muscle relaxers, and many of them in suppository form, suppositories with ketamine, baclofen, diazepam, which is a benzodiazepine, which is a very good muscle relaxer, but like did not help me. And then I did all those Botox injections, and I think maybe some of the Botox might have helped the allodynia on the surface of my skin back by my sit bone, the ischial tuberosity. And that would not have been really working on the muscle component because it was the surface of my skin that felt a little bit better. There's some interesting research about using Botox subcutaneously for neuropathic pain and other kind of pain, not intramuscularly, not just for the muscle relaxing effect. Botox can actually have some sort of nerve impulse inhibiting effect and pain relieving and anti-inflammatory effects, but it's not like really proven yet in its knowledge, and using this as a tool isn't really widespread yet. You can find a few reports online of people getting Botox into their vestibule for vestibulodynia. That's kind of interesting, but there's not a lot out there. So I really recommend everyone with vulvodynia, especially if you have no idea what's going on and no idea what caused it, get assessed and look into this. But also I want to tell the world that that pelvic floor dysfunction is not the only cause of pelvic pain. It can be a miraculous cure for many people, and it can do absolutely nothing for others. We do need to get a better handle on when it won't help people so we don't waste their resources.